the results of the Relieve heart failure study. A lot of controversy after the presentation. Dr. Stone's presentation indicated that there may be hazard in the HFpEF patients who have an interatrial shunt placed. I wanted to talk to the two of you about your perspective. I mean, I'll start with you, Sanjiv. You were the discussant. Talk to us a little bit about your perspectives. Is it dangerous? Is this technology dangerous in the HFpEF patient? Should we be doing trials in this space?
Well, thanks, Mike. You know, I'm looking at it from my perspective of having worked in this field for the last 15 years, starting at the very beginning of the Corvia atrial shunt device and serving as the global PI for the Reduce LAP HF1 and 2 trials. And we really have learned a lot about atrial shunting from those trials. So I was really excited to see the Relieve HF results. And I think that, you know, the characterization that atrial shunts are harmful in HFpEF, I think is an oversimplification of the story, because from the get-go, we knew that Relieve HF was enrolling a very sick patient population. They had presented their roll-in data a few times, and the first approximately 100 patients in their trial were roll-in patients. So they had some presentations. They now have a publication on the HFpEF versus HFrEF in that open label part of their study. And from that, we found that, you know, those patients really were quite sick. They had, you know, in some cases, moderate or more RV dysfunction. They had elevated NT-proBNP levels, you know, of the 1,500 or 1,600 was the mean. You know, they were really kind of advanced patients. 20% in that trial, we found out, had moderate or greater tricuspid regurgitation. And, you know, they didn't undergo exercise invasive hemodynamic testing. And so we think about that type of patient, the patient with the vulnerable right ventricle that has, you know, moderate tricuspid regurgitation. They may be in a low output state. They have a high resting PVR. That's the kind of patient that we found in the Reduce LAP HF2 pivotal randomized trial that was a non-responder.
So it confirmed your previous results.
Exactly, yeah. So, you know, just for the audience, the Reduce LAP HF2 trial was also neutral, like Relieve. But when we did the responder analysis, we found that 50% of the patients who had a low exercise PVR, so during exercise, they didn't vasoconstrict, they appropriately vasodilated their pulmonary vasculature, and they didn't have a pacemaker ICD, which we think is a sign of, you know, a sicker LV and RV. They did quite well. You know, they had a 50% reduction in heart failure events. The KCCQ went up 6 points compared to sham. But the non-responders, so if they had an exercise PVR that was high, so this latent pulmonary vascular disease, or they had a pacemaker ICD, at 2 years of follow-up, they actually had a twofold increased risk of heart failure events, and their KCCQ got worse. So when you put all of these groups together, you have sort of the Corvia Reduce LAP-HF2 responders who are just as symptomatic, but they have these lower risk features. So their NT-proBNP is about a third. Their resting PVR is half of what we saw in Relieve HF. Then you've got the Corvia non-responders, and then you've got the Relieve HF HFpEF cohort, and they are the highest risk, sickest patients. So I think where the field is kind of coming together is that phenotyping in HFpEF, as we know, heterogeneous syndrome, is really important. And if you enroll patients that are sick with sick right ventricles, vulnerable, they really are not going to improve with the device. And so I think
high PVRs.
Yeah, high PVRs. And I think, like you said, we sort of, my deep dive discussion at ACC was that, hey, these are, at least in HFpEF, which is all we've studied thus far with the Corvia device, these are concordant results. And actually the field is gravitating towards really understanding which HFpEF patients don't benefit and which patients we hope benefit.
Jim, from your perspective, how are experts like you digesting the information and what's happening with current trials? I know a lot of trials were planned. Has this really impacted those plans?
Well, I think we were all a little bit stunned when Greg presented those data, but honestly, within 24 hours and then seeing Sanjiv's presentation on Sunday, I think the dust began to settle, and it quickly became clear what Sanjiv has just explained, that the Relieve-HF HFpEF patients were a much sicker population than is now being studied in the trial that Sanjiv is doing called Responder-HF, focused on those responders, and then a trial that I'm involved in called Allay-HF with a no implant approach to creating an atrial shunt from a company called Alleviant, which is modeled exactly on Sanjiv's responder group. So I think, what we've learned from the 10 plus years that Sanjiv's been doing this and all of the others that are evolving here is that, this intervention unloads the left atrium, but loads the right ventricle and the pulmonary vasculature. And you have to find that balance of the right ventricular function and pulmonary vasculature that can handle that to get the benefit. So it's just the balance of the benefit and the risk. And I think the responder analysis of reduce LAPHF2, that's probably the strike zone of who is going to benefit without the downstream risk. And, in Sanjiv's trial, that was hypothesis to be tested. And now 2 trials are testing that exact thing. So we will learn a lot from this. But I agree that the patients, Relieve-HF HFpEF patients were sicker. NT-proBNP was much higher. RVs were not as good if you look down, and so that was not the strike zone. And they looked very similar to the non-responder group, as Sanjiv said.
Yeah.
On the pharma side, we always say you got to give the right patient the right drug at the right time at the right dose. Here on the device side, you got to give the right patient the right device.
Right. Yeah. And in some ways, it's almost like the MitraClip story.
Mm-hmm.
If we stopped, when Mitra FR came out, this doesn't work at all. But and then, couple months later, when Greg presented the COAP data, here's the strike zone, not large ventricles, proportionate versus disproportionate MR. This story perhaps is not unlike that. You're isolating the MR and you're taking away a volume load for the LV, but you're increasing the afterload. And can the LV handle that? And COAPT found that right group of patients in theory. So this is not unlike that, I think.
Sanjiv, any additional comments?
Yeah, I would point people to a recent paper that we just published in JAMA Cardiology, where Jim is an associate editor. And this paper is on the long-term follow-up of the echocardiographic results from the Reduce LAPHF2 trial. And there we learned a lot as well. We learned, what happens when you put a shunt in a patient with HFpEF and how do responders differ from non-responders. And, I think the listeners will understand that if you have a vulnerable right ventricle, or you have a lot of TR, or if you have a pulmonary vasculature that's sick, you do shunt blood from the left to the right, but then the blood just sits there. It doesn't go anywhere, and then now you have an underfilled left heart, your cardiac output goes down, your right-sided pressures go up. So it's not surprising that the sicker you are, the worse you're going to do with that. Now, if you're a responder, the blood does shunt, but everything else gets better. It gets to the left side, the left atrial function gets better, output is maintained out of the left side, and wedge pressure, left atrial pressure comes down. So, I think that I would say that just on putting my clinician hat on, I am a little worried about, these devices just getting out there and people just using them willy-nilly. I think that we've got to be really responsible as a field to really understand who benefits, and who will actually, get some improved outcomes and symptoms and not actually do worse and potentially die. We saw that there was a 3-fold increased risk of death in the HFpEF patients in the Relieve trial with the V-Wave shunt. So, my hope is that we succeed here and that we have a new therapy eventually for HFpEF patients. But I think we need to be really, really careful about how we implement this in clinical practice.
Yeah, and just in follow-up to that, in terms of safety, I think it's important to point out that Sanjiv presented at the recent THT meeting in Boston in March, the 3-year follow-up data of that responder group. And they're still doing well and still about a 50% reduction in heart failure events. So, the data are building, plus the echo data that Sanjiv just said. And we will learn because now there's, hundreds of patients being studied in these ongoing trials targeting those people who we think should benefit.
And they're tolerating it well, Sanjiv. Their PVR is not going up. Their RVs not, showing signs of later failures.
Yeah, it was, in that JAMA cardiology paper, we show across the board, responders, non-responders, they're not dying of right heart failure. They're not getting hospitalized with severe right heart failure, severe TR, there've been a handful of cases where we hear about that, but we then investigate further, and closing the shunt wasn't the treatment. It was really diuresing the patient or, fixing something else that was going on. And so if the inappropriately selected patients, I don't think we're seeing any issues with reversal of the shunt or closure of the shunt, like spontaneous closure of the shunt or anything like that. So it's interesting, why are these non-responders getting hospitalized? It's probably that they can't tolerate a stressor. They can't augment their cardiac output because all the blood's getting stuck on the right side. But it's not that they're getting severe right heart failure from RV overload. That doesn't seem to be the case.
Interesting. That might have been my suspicion from the outset. Final words, Jim?
Well, I think this is how clinical trial science should evolve. You learn from each trial, you get really smart after every trial is done, and you apply it prospectively. And I think these ongoing trials will teach us, what is that strike zone? So it's really as science should evolve.
Don't strike down the technology, find the strike zone. All right, you two.
Exactly.
Thanks for your time today. Thanks for joining me. And thanks to all of you in the audience for taking a listen. I thought this was fascinating. Thanks, guys.
Thanks, Mike.
Thank you.